Good morning, everyone. My paper is on clinical profile of anisometropic amblyopia and its outcomes to treatment. Amblyopia is defined as the reduction of visual acuity in one or both eyes by abnormal binocular interaction during the critical period of visual development. So it's clinically defined as the difference of 2 lines or more in a visual acuity table. And the incidence of amblyopia in India, according to a population-based study, was 1.1 to 2.5%, and in tertiary eye care was 11.4%. There are different types of amblyopia. Among them, most common is the anisometropic amblyopia, and is defined as the difference of at least one diopter in refractive error between the two eyes. So, diagnosing amblyopia is very important because it is a silent cause of visual morbidity in children. The aim of our study was to assess the visual outcome to various treatment modalities in children aged 4 to 12 years with anisometropic amblyopia. It was a prospective study conducted in Tertiary Eye Care Institute among 139 children with a study period of 1 year, and the visual acuity before and after 6 months of treatment were statistically analyzed. The different modalities of treatment given were glasses, patching, and computer-based amblyopic exercises. We included children under the age group of 4 to 12 years with refractive error and isometropic amblyopia. We excluded other types of amblyopia, children with squint, children with corneal pathologies, cataract pathologies, and retinal pathologies. So we could find that there was an equal distribution of male and female among our study population. And most of them belonged to the age group of 4 to 7 years. And we could see that most of them had mild amblyopia, then moderate amblyopia. And the most common type of refractive error that we encountered was astigmatism, followed by hypermetropia, then myopia, then compound myopic astigmatism. So among the 139 children, all of them were given glasses, and options of patching and amblyopia computer-based amblyopic exercises were given. 120 of them opted for patching, and 19 of them opted for computer-based exercises. And after 3 months of assessment, we reviewed the patient, and 29 of them needed another mode of amblyopic exercise that was computer-based, and 91 of them did not need any exercises. That is computer-based exercises. We came to a result that there was statistically significant improvement in visual acuity in all categories. That is glasses with computer-based, glasses with patching exercise, and glasses with patching and computer-based exercises. And we could see that there was more improvement with glasses and computer-based exercises than glasses with patching. So our study had a sample size of 139 children, while another study by Cabby et al. Included only 50 children, and Holmes et al. Was a meta-analysis study, included 996 children. The age group of all the studies were similar, and the follow-up was also similar, that is 6 months. We studied only anisometropic amblyopia, while Cabby et al. And Holmes et al. Studied all types of amblyopia. And the treatment modalities that we included were glasses, patching, and computer-based, while Cabby et al. Included patching and atropine, and Holmes et al. Include patching, atropine, and Baumgartner filter. All of the study concluded that there was visual acuity improvement in all the treatment, while Cabby et al. also found that atropine was effective as patching, and Holmes et al. Concluded that amblyopia was more responsive to treatment in younger than 7 years of age. From our study, we could see that the astigmatism was the most common refractive error, and glasses along with amblyopic exercises showed faster improvement than glasses with patching. So amblyopia is one of the leading causes of childhood blindness. Early and standardized amblyopia screening is thus needed, as anisometropia can be asymptomatic. Regular follow-up was a crucial part of the treatment, and urgent intervention is of paramount importance to prevent irreversible and lifelong visual morbidity. These are my references. Thank you.
In these 6 months, how frequently did you, were the patient called back for review?
3 months review.
Every 3 months.
Yeah.
What was the line improvement at the end of 3 months?
About 1 to 2 line improvement in visual acuity was seen.
1 to 2 line. Along with this, was the stereopsis also reassessed at the beginning and at the end of 6 months?
At the beginning, it was assessed, but at the end, we did not assess.
You have done conventional occlusion, no? You have
Sorry,
done conventional occlusion,
yes, sir.
that is normal eye occluded.
Normal eye occluded, sir.
Do you have any formula for that? That is how many days you have to wear as per age. Your patients or what age patients?
4 to 12 years of age.
What told you? How many days you have given permanent occlusion for the normal eye? That is occlusion. And then how many days you have to occlude the amblyopia also?
Uh, until the refractive error becomes, until the best corrected vision becomes 6.
Okay. Can I ask one question? That is, what is inverse occlusion?
Following occlusion of the normal eye.
Inverse occlusion. When will you do inverse occlusion? Because we are preparing for exam. Imagine I have come as examiner for you. I am asking this question. Where will you apply inverse occlusion? No. That means in cases of eccentric fixations, you have to occlude the eccentric eye to remove the eccentric point. Then afterwards, you have to stimulate the macula of that eye with after images test. That is called pleoptics. Have you heard about pleoptics?
No, sir.
Pleop. Pleoptics you have not heard. Pleoptics means eccentric occlusion eye cover and then remove the eccentric point, then stimulate the macula. These are all some of the short notes you get. Squint.
Okay, sir. Thank
Original crux is that anisometropia.
you. Yes, sir.
We aren't sure how much of anisometropia was there in your study group. How much difference between each eye and how much of correction was forced upon them. Those things also should be given. That should be said because you are stressing more on the amblyopia treatment than anisometropia treatment. We presume that from your study that you have pakka corrected anisometropia and not to amblyopia treatment. But your study, if you publish somewhere, will also need data on that.
Okay, sir.